previous meeting in Loiano was held 4 years ago. It has left an important mark. There was, well, a stepping stone for our association and for the families that on that occasion met for the first time. So I will meet, well, new faces. Now our children grew up. We have new families. We have new children. We have new medical doctors we're now working with. So we have become friends. So it's a very strong relationship that we managed to, well, establish with them. Now, this is a very special meeting for us. And, let me just tell you about the, well, the reason why we are here in beautiful Cervia today. You know that one of our families, one of our children, passed away 2 years ago. Simone was from this city, Cervia. So this evening we will have a specific award. It's a financial contribution for the best thesis on this syndrome. So we are here to honor the memory of Simone. We wanted to be here in Cervia for this unique and special occasion for all of our families, because we feel so close to them. We are a large family, so a few families, very different, very diverse, coming from different regions of Italy, but also from other countries around the world. But we are deeply united. Tonight, during our gala dinner, we will, well, let's say we will celebrate, this event. We will strengthen our, cooperation, and we will celebrate all what we are doing together. We've done so many things in the past 6 years. Since the very beginning of our association. I'm sure this is so important for our children. Now, because we are here to talk about the future, we want to talk about the management of the life of our children. So we want to focus this meeting on the, well, daily issues. And, well, we have so many things we will go through, so I hope this will be one of many meetings, what our, issues and daily problems are, very diverse issues. So this is very first meeting. We won't be able to be exhaustive, so we will try and, go through some specific issues, and I'm sure, medical doctors who are now working with us. And, once again, this is a very important opportunity for us, but also for the medical profession. This is a sort of a platform where we'll exchange experiences, expertise, and so we hope this partnership, is here to stay. This afternoon, we will be talking about, daily problems, daily issues. We will be talking about young medical doctors. We believe in them. We trust them. And they come from a very important school. They have been trained by other, medical doctors. I'm talking about their age. They have, plenty of expertise and experience, even if they are young. You will meet them this afternoon. So we will be cooperating with, top medical doctors. And we are really so proud that they are working with us. They are always here with us. And there's a person who's always ready to understand our needs. Of course, I'm talking about Professor Cocchi. Let me give the floor to him. Once again, thank you so much for being here, and enjoy the Congress. Well, I have to thank Samantha, because, Samantha has, striven to put together, this meeting since the birth of Giacomo. She's been showing incredible commitment in the past, 6 years. I have a very short PowerPoint presentation just to walk you through the, meetings we had and things we have done. I met Mrs. Carletti when she delivered, her third baby, Giacomo. Okay, very short, overview. This is for, the families who just stepped into the association. So you can really understand what we have done together in the past years in terms of our association. Anyway, Giacomo, a nice infant, but there were some key features requiring focused attention. So we needed to really focus once again on some aspects, some points that had to be defined. Okay, let me skip technical details, but you can see here the position of the ears. You can see here the position of the nose. Now the face is very nice, but we had some some doubts. So this is why we have started cooperating with Samantha. So we had some doubts. We were a little suspicious that something may not be working correctly. I know it's not easy. Having a diagnosis is difficult. We will be talking about this during the day, but in terms of genetic points, the diagnosis is definitely difficult. So we have cultured peripheral blood, and in that culture we saw that one special chromosome was there. So the first description of this situation was done by David Pallister in 1976. This is what he saw. Recurring aspects on the somatics of the face, the so-called Gestalt diagnosis, and this was a common element. So that was a time where diagnostics was kind of invasive or complex. At the very beginning, we thought it was an extra chromosome belonging to chromosome 20 because of the resemblance. At that time, we didn't have, band examinations. This banding, gives us the possibility of, really see the chromosome. But in 1977, so 1 year later, they were able to identify this as isochromosome 12. It's extra chromosome that you can find in the investigation. This is a plate of what the biologists can see. If you count them, you don't have 46, but you have 47. So if you sort of distribute the chromosomes, based on the traditional classification, this extra chromosome that you can see here, by the way, and it's very similar to chromosome 20. So this is why there may be some, confusion without this, technique, because this is a new technique that's available. Anyway, you can see this extra chromosome. Even if it's very small, it triggers plenty of, clinical consequences, which are so important. So after the first description, we then saw plenty of publications. So when Giacomo was born, we had around 130 items or papers in literature. Now we have 188. So in recently more than around 60 new articles or reports were published. On average, 10 new publications a year. You can see here a progressive growing interest for this condition with plenty of publications. You have important, let's say, baseline reviews, case studies, and now we know it's a rare condition. The incidence is 1 every 25,000 up to 1 to 50,000. So it is sort of difficult to identify the situation soon after birth. Now, many papers are now focusing on, genetics and genetic modifications, together with the prenatal, diagnosis systems. Now, this is a very hot topic because, you can really do this now prenatally, so before birth, together with postnatal, so after birth, diagnosis systems. So what's happening in Italy? Let me share with you a very short overview on what's happening in Italy. Thanks to Dr. Carletti, we started a program 6 years ago. So first of all, we had the association being established, so PKS Italia, working with the PKS from the US. So as Samantha said, back in 2013, we held the first European workshop in close to Bologna. We had Italian families together with many other families coming from other European countries. As Samantha said before, it was, well, that was a milestone meeting because we allowed families to meet. I mean, people, having the same problem that Samantha has. So we've been able to, start cooperating thanks to the, participation and help of many other families. For example, Sarah's families. In 2014, in Bergamo, close to Milan, they have put together another meeting in order to collect funds and promote research on the PK. Now, that was such an important meeting. Well, first of all, because, I mean, we've been able to disseminate, information. We raised awareness. I mean, mass media talked about this. So we now know what we have to do to improve the health of our children. So that day, during the fundraising dinner, we managed to get some money for a grant, and that grant was delivered to Mrs. Salzano in December 2015. Mrs. Salzano, by the way, will be here this afternoon. She will be talking about her own experience. She's now working in Philadelphia in the US at the Children's Hospital in Philadelphia, where Professor Kranz works. I mean, he's the international expert working on this condition. So that was a nice, let's say, training opportunity. We have met, experts that will help us assist our children. But that was also a major step forward in terms of research. Once again, a very important, event. There's been a major national awareness-raising event. So the grant was important, not just for the value, I mean, not just for the money, but we've been very lucky that day. Professor Salzano has specific, background focusing on rare genetic diseases. So I'm sure that the contribution that she will be able to give, I mean, she will, now work on an international level. So all of this will definitely help us. There's also been, that day at the first international meeting in Bologna, we managed to publish a paper with the participation of Professor Kranz. So we talked about dentistry and, the consequences on the stomach of our children. So back in 2013, our partner, Dr. Alessandro Rocca graduated. So he drafted a specific paper on PK. He did something very important. So he managed to collect, as many data as possible, and he put together, knowledge available at that time on this condition, on PK. 4 years later, that was exactly July the 13th this year, so a couple of months ago, we had another graduation. This is another student, well, actually a doctor now, and he also wrote this, thesis on the assessment of prenatal profiles and postnatal clinical profile. Now, this is a key attempt to try and, highlight the key aspects, the most typical ones in our population. So this is, showing growing interest about PK. This is what we have to do and we will have to do to improve knowledge, to give better assistance to our families. And, based on all of these inputs coming from different skills, competencies, and places, we managed to put together this meeting. I mean, this is the second European meeting. Hopefully, we will be able to get, as many fruits as possible in terms of disseminating, widening knowledge. We need now new tools and new possibilities of interaction between different, specialists, medical doctors, helping, our children grow. So, once again, I'm sure the meeting will be fruitful, and I'm sure we will get great results thanks to our cooperation.
Allora, adesso quindi
I'm now inviting Dr. Anna Maria Magistà. She's from the Neurogastroenterology lab from the Pediatrics ward in a local hospital from Ravenna. Thank you so much. Good morning. It's a pleasure for me to be here, and I'm officially opening the second workshop on PK. Really would like to thank our colleagues for this invitation. I really would like to thank the PK children families for being here, in particular the family of Simone and Anna, the two children we had the joy to take care of in our lab. Anna is here this morning. So let me start from Simone and Anna to talk about the main nutritional gastroenterological problems that you have with this syndrome. Now, Simone was referred to us with a specific diagnosis. He was 2.5 years old. Regurgitation and vomit, so a reflux with medical treatment. Respiratory problems with some pneumonia and reiterating, relapsing, infections. We see that feeding is difficult with solids but also liquids. It takes a long time with cough and inconsistent voice. We have, hyponutrition, so there's malnutrition, and cleft lip waiting for surgery. Anna comes to us when she's 9 months old, undiagnosed at that time. The reason was she couldn't accept solid food. Especially soon after weaning, so around 7 months. She finds it difficult to manage liquids, and then you can see a progressive reduction of weight gain. She has an anteriorized anus. Now, if we consider these key aspects, we can really, draft, this situation. So we have dysphagia, they have, let's say, disorders or feeding disorders, possible dysmorphisms of the gastrointestinal tract of GI. If you want to assess the prevalence of these disorders, we have to consider two main population studies available, one from the UK, another one from the US, from Philadelphia. So based on these two papers, we see that these problems are basically frequent comorbidities in our children, because this is what happens in a highly variable, percent rate of children, from 30 all the way up to 70%. So let me now talk about dysmorphisms of the GI tract. Of course, the next speakers will be more exhaustive on this point. Anyway, this is the typical aspect Professor Cocchi mentioned. So we have the Pallister lips. The aspect of the lips. Now, you may have the lower lip, which is protruding. You have micrognathia. This means that the the jaw is small. This is what happens especially in the first years of life. And then you have prognatism. And then you have macroglossia. Now, this condition may have clinical consequences. Problems in terms of feeding or nutrition. it's difficult to control saliva, to keep saliva in the oral cavity, sialorrhea. Now, the palate may also be dysmorphic. You may have cleft palate in the hard part or even in the soft part of the palate. You may have a high arched palate. Dr. D'Alessandro will be talking about odontostomatology and dentistry. Now, these conditions have consequences in terms of nutrition and respiration, especially in those cases where you have cleft lip or palate, because if you have this sort of interruption of the palate, there's a direct communication between the nasal cavities. The problem is that food may be inhaled, thus generating respiratory problems. As for hernia, now hernia is a frequent pathological condition that we find frequently in these children. There's involvement of GI, basically on the diaphragm. Now, the diaphragm is a flat muscle that separates the thorax from the abdomen. And this condition is created during the intrauterine life. So some organs, some parts of the body here moves upwards in the thorax. So they compress, they compromise the lung. This condition, in some cases, can be diagnosed and in the most severe cases, we can also have intrauterine surgery. The problem is that, the lung is compromised. There's an abnormal development. This condition deserves surgical correction, but over the years, this may lead to respiratory functionality problems, gastroesophageal reflux, and scoliosis following surgery. Other, locations for the hernia, you have the umbilical, so the navel area. In important cases, you may have some abdominal areas protruding and being expelled out of the body. So once again, this requires surgery. The gut, so the intestine, may be altered during the embryogenetic development. In the list of malformations we see frequently, we have the malrotation of the gut. You may have also some malformations of the anus and of the rectum. So Anna, for example, had this anteriorized anus. And the possible consequences, if you have malrotation, you may have obstruction of the gut, or many other cases, for example, with constipation in case of diseases. In terms of the gastroesophageal case, we have around 40% of involvement. Anyway, possibly the incidence of this condition is higher than 40%. Anyway, this is the reflux. It's acid material, coming up from the stomach back to the esophagus. Now, within these limits, this is normal. I mean, sometimes we do have this experience. I mean, acid material sometimes may, move up. But if this condition generates symptoms, then you fall within a real reflux disease, which is the real actual disease. And apparently, in the PK children, it involves, as I said before, 40% of cases. We have different factors that we have to take into account. Now, there's an alteration of the motility of GI, which is usually altered. And then these children privilege liquids. I mean, they like liquids. So unfortunately, liquids move up, easily. And then because of hypotony, they usually lay on the bed. So there's no alignment between these parts of the body. So what are the symptoms that you can see? Now, the key symptom is regurgitation. So the fact that this material or liquids move up from the stomach up to the esophagus. In some cases, you can see it from outside. I mean, the parent sees the presence of this material coming up. An important sign is the wet, linen or bed, or even the pillow. So if you find, some acid material in the morning on the pillow, this comes from the, gastric tract. There may also be a hidden, so occult regurgitation, so you don't see the material, but you see the child, being in discomfort. I mean, pain, for example, because once again, this material, acid material, is regurgitated. Vomit may be one of the external manifestations. You also have the inflammation of the esophagus, because if you have acid material there, there's inflammation of the esophagus. And maybe the child cries, or he or she refuses meals, presence of blood in the vomit, or once again, some blood, this is anemia. What is very important is the fact that the reflux also generates respiratory symptoms. For example, the reflux from the pharynx together with an impact on respiration and chronic cough. I'd like to draw your attention on another possibility. Quite often, respiratory symptoms and pulmonary pathologies are, seems to be the consequence of reflux. But PK children frequently fall within this framework. What is difficult for them is, swallowing food or dysphagia. And this is, one of the consequences is respiratory problems. You can see here dentistry abnormalities. Professor D'Alessandro will be talking about this in the afternoon. Possibly this acid material moving up into the oral area may attack the coating, if you will, of the teeth. So parents tell me in these cases that that there are limits for this diagnosis. The diagnosis may also be instrumental. I can use tools, examinations like the impedentiometry, so measuring the pH, gastroscopy, or X-rays. Now, point 1 and point 2, well, these are the two most important examinations, but this is quite invasive because, of course, you have to introduce a probe through the nose and, it has to stay there for 24 hours. Sedation is required for gastroscopy. Now, these children are, fragile, weak. Every child having, neurological problems, for them, we need to have a so-called instrumental examination. There's a very recent position paper from the Pediatrics Gastroenterology Society, very important association, and this was published last month. This paper says that in neurologic problem children, just because this is a population where reflux is so frequent, we may avoid invasive investigations if I have a strong clinical suspicion. Regurgitation, vomiting, discomfort. So what can I do? Well, I can start with drug therapy. So a pharmacological therapy, there's a very strict follow-up of the child. If the therapy improves the clinical framework, and by the way, the treatment has to be a long-term one. So I necessarily have to have, let's say, an instrumental confirmation of the diagnosis. I cannot give, years and years of therapy without confirming the therapy. This happens because the drugs we use include basically drugs that stop acidity, the so-called pump protonic inhibitors. Meprazole, lansoprazole, and many other azoles. So they, let's say, reduce the acidity in the stomach. So this means we remove the complications of the esophagitis or a reflux. But on a long-term basis, this may generate respiratory infections, for example, the malabsorption of B12 and other micronutrients. So once again, if you think the treatment will be a very long one, you have to go through invasive examinations to confirm the diagnosis. This is also important in the therapeutical approach for the child, so the diet has to be changed. Formulas have to be thicker, or you may want to use special milks. This is also an important point, malnutrition. There's an Italian paper from one of our colleagues, Mr. Campanozzi from Southern Italy. Anyway, neurologically impaired children, especially if they are malnourished, I mean, reflux is much more frequent there. So if we remove malnutrition, well, this is a great improvement, I mean, in terms of stopping a reflux. This is another problem I'd like to talk about, constipation. This happens quite frequently in PK children. Prevalence is 65%. So how can we define it? You have non-frequent evacuations, usually 2 a week, or feces which are thick or hard, or the need of using laxatives. In this case, just like reflux, there are many factors that you can find in neurologically impaired children or PK children. So constipation depends on many problems. Gut motility is slowed down. Muscles are hypertonic, so weak. The child doesn't move. I mean, in terms of mobility, there may be pathologies of the anus, and there's almost no water, no fiber in his or her diet. How can we diagnose constipation? Well, of course, based on the patient history, so the anamnesis, how many evacuations a week, the volume of the feces, and even the thickness and texture of feces. Now, constipation may happen also in children that apparently, evacuates every day. So parents tell us that everything seems to be normal, small quantities of feces. In terms of thickness, it's just like, a chocolate cream. But this is a constipation because the hard feces coming from the top stop in the very last part, in the final part of the gut, and they cannot be evacuated. So feces coming from the top, they are softer, they are filtered, and we can find them in terms of, very, well, liquid, if you will, feces. Parents see feces. We think, or they think, evacuation is there, but the problem is that there's fecaloma, so there's a mass of feces, in this position. It has to be removed. So what can we do to solve constipation? Well, we have to work on the diet, so more water and more fibers. As you know very, very well, what is very difficult in dysphagic children is exactly these products, I mean, fibers and water. So we use drugs that make feces softer. Regolin, Macrogol, I mean, it has different, commercial names. Anyway, in these children using this product, we have a key message for parents. If the child is dysphagic, this product doesn't have to be administered in water, but you need cream, for example, thick gel, or, for example, fruit, creams, because there may be chemical pneumonia with Macrogol. So in constipation cases, you also have to work on predisposing factors. If you have an infection of the anus, once again, we have to use antibiotics. This is another aspect. I mean, this is an alteration of the mobility of the gut. And quite often, even if you use, these, probes, I mean, Macrogol, the child also has to be stimulated from the, from the anus. If this is necessary, don't use phosphate sodium. This one, for example, this is widely used. Don't use it because our children generated electrolytic unbalance. So please use natural solutions based on honey, for example, and use this, physiological solutions, Vaseline oil. Please do not use these commercial products for. Now, let me give the floor to the speech and language therapist.
Buongiorno a tutti. for just a few seconds for the presentation to be ready. Okay, so good morning. I actually tried to look for studies in literature about dysphagia and PKS. The first study was carried out in 2014, and among all the features of this syndrome, hypertonia and motor disability were detected. And actually, these two factors can result in dysphagia or nutrition problems. Actually, a study was carried out and 22 British patients were enrolled. And in PKS babies, actually, hypertonia is the cause of nutrition problems. So they described all the clinical features of the babies, and actually, 2 babies had nutrition problems among the ones enrolled in that study. This is another study conducted by Professor Cocchi in Bologna, and Professor Alessandro later on in the afternoon will illustrate this study. So actually, they identified a number of features when it comes to the mouth and the teeth. And this is actually something that we have already said. So the Pallister-Killian lip, the late eruption of teeth, cleft palate, and also problems when it comes to anterior open bite, for example. Sorry, I have some problems with the slides. Okay, so actually, when it comes to the medical history of the children, 2 were actually identified as having dysphagia, so 2 children out of all the children enrolled in this study. Whereas this is reports about a study on 59 children, and out of 59 children, 32 have been recognized having dysphagia, which means 48%. And when it comes to feeding difficulty, so you have actually this percentage. So having said this, what can we do when we identify feeding and swallowing difficulties? Well, all the authors in literature agree on the fact that 3 elements have to be considered. First of all, the general history of feeding, the mouth and face structure analysis, and also the meal assessment or evaluation. So first of all, the medical history and also the history of feeding of the child is actually collected. So when it comes to the prenatal, perinatal, and postnatal development, any hospitalizations, the use of cannula, for example. And another important thing is actually getting information from the parents about the motor abilities or the motor development of the child. And also when it comes to the feeding history, in terms of, for example, breastfeeding or weaning, so all the information, and actually if the child had problems in dealing with different consistencies of food. So these are all the information we collect. And we also ask parents about food, so if they actually use liquid, semi-liquid, or solid, semi-solid, or chopped food, and also the taste features, so if the child prefers like bitter or sweet food. So this is all the information we ask parents. And also we ask whether they use any feeding aids, for example, what the caregiver uses, for example, a silicone spoon or metal spoon, what kind of butter, like a sippy cup or not. And another important element is the posture of the child. So if is actually the child is fed while sitting or in a high chair, and also what is important also the caregiver's posture. And also we ask whether during the meals there are kind of signs of inhalation of food. And also we ask for the duration of the meal, which should be half an hour. If it is longer than half an hour, this means that there is something which doesn't work, so there is something wrong. So in this case, we should investigate further why the meal takes so long. So what are the difficulties of the child? So is there a problem of swallowing or a problem of acceptance of food or a behavioral problem? So these are all the elements we assess. So after gathering all this information about the child, we also evaluate the face and the mouth structure. We look at the head, chest, and pelvis alignment, which is important when it comes to feeding. We also look at the respiratory method in a way of the child, and we also look at the structure of the mouth and face. We look at the lips, the way they close the lips, the presence of hypotonia, for example, when it comes to the tongue. We look at the cheeks as well, the palate, the presence of cleft palate. And so after such a very accurate assessment, we also look at the possibility of vomit and cough. During our assessment, we also try to understand if some pathological reflexes are present, which shouldn't be there, but actually they can affect feeding. For example, the bite reflex, for example. So these kind of reflexes affect the behavior when it comes to nutrition. We also look at sensitivity. There might be children who are hypersensitive or hypersensitive. So we look at the sensitivity of the upper limbs, the mouth, and also the perioral area. When it comes to hypersalivation, well, sometimes hypersalivation is considered as the problem, but actually the problem is that saliva is not effective, so actually it builds up in the mouth, and this is also associated with hypotonia problems, and so due to that, saliva actually comes out of the mouth. So during our assessment, we also look for the presence of salivary. Now we also assess the feeding, let's say, session. So we look at the child while eating. Sometimes we look also at videos made by the parents. So we look at the behavior of the child with the food. We look at the posture of the child and also the posture of the caregiver, the consistency of food, and also if any administration aids are used. We also rely on saturimetry, so we look at oxygen saturation and also cervical auscultation. Despite there is no scientific evidence about the effectiveness of cervical auscultation, however, we know that both saturimetry and cervical auscultation, together with other elements, can provide important information. At least based on that, we can carry on with other analysis. Now I would like to introduce Anna. She came to our lab when she was 10 months old. When it comes to her history, well, she was breastfed up until 7 months. When it comes to weaning, well, they had experienced some difficulties, And at the moment, she eats creamy food. She sits on the high chair. However, there is a difficulty in maintaining aligned all the body parts. When we first assessed this girl, well, the first time the diagnosis of PKS was not ready yet, but we look at the face and mouth, and we noticed a very thin upper lip, hypertonia when it comes to tongue and lips and cheeks, and protection reflexes that were present. Then we actually look at the food, so the, let's say, feeding testing, so with a creamy food. So basically, she had a suckling movement of the tongue. So and also we noticed tongue protrusion. We didn't notice any sign of inhalation, and she had some problems in managing liquid. So we'd like to show you a video clip, and we thank the father for sharing this with us. So here you can see all the difficulties in feeding when it comes to posture, so hypertonia, and also maintaining the food inside the mouth, the protrusion of the tongue. So you can see in this video clip all these elements. In particular, tongue protrusion is quite clear, and you see that food comes out of the mouth. So based on a first assessment, we provided some indications to the parents and the team taking care of this baby. So they had to find the right posture in order to ensure the improved alignment. And also we tried to actually implement some inhibition maneuvers when it comes to the tongue protrusion, and we wanted to train the baby to use the glass for the liquids. Now, a few information about posture before giving the floor to my colleague, Mrs. Nanni. Well, posture is crucial. We have to find the way in order to ensure the head, trunk, and pelvis alignment, because we know that with this type of posture, they can actually eat better. So the posture systems or aids must be identified. You can see some examples in the slides. And also the caregiver posture is as important as the baby one, because some postures are not, let's say, convenient for parents. Some parents hold the babies, and this is extremely difficult. And actually, these positions are not safe as well. So if you look on the top right corner, well, these are actually incorrect. If you look at the position of the head, which is actually leaning backward, and also the posture on the wheelchair must be the correct posture. So you see the other ones are the correct and safe ones. Now I give the floor immediately to my colleague. She's actually a speech therapist working in our hospital. Thank you. Good morning, and thank you for inviting me today. I will enter into details to talk about what Anna is doing at our hospital in Cesena. And I will give you some examples of the activities that we actually perform together with her. This first slide shows you information about the condition of Anna. This is actually the last visit. So this is information from the last visit. When it comes to sight, well, we are still trying to understand if she actually uses, let's say, sight. So we found extropia, normal fundus, and she wears glasses. When it comes to hearing functions, well, that is, let's say, within the normal range limit, but when she was younger, we detected a sort of a hearing impairment for high frequencies. However, no acoustic aids were necessary. No problems when it comes to neurological features. And as to the neuropsychiatric visit, this confirmed hypertonia, poor control of the trunk, and poor participation in the environment. Now, what are we doing? Well, physiotherapy, speech therapy for communication skills, speech therapy for oral motor skills, psychomotor activities, and last year she attended a kindergarten for some hours to provide some social experience, which is very important for this girl. Now, as my colleague has said, our main goals after the assessment made in Ravenna in particular, so we would like to actually decrease the sensitivity of the oral and perioral areas. We want to train chewing, so in order to improve the muscle tone, and in particular, we also would like to change the consistency of food, and also the important thing is the mouth hygiene of the child. So with Anna, we set, let's say, very small or minor goals. So every single time we try to consider different ways of approaching her. And well, one important achievement is that Anna actually expresses her feelings. So she tells us in a way if she likes or not what we are doing with her. And I have some video clips that show what she likes, what she accepts. So first of all, we started working on decreasing the sensitivity of the oral and perioral area, and that was the very first thing to do, because after that, everything becomes easier. Of course, I have to respect the child, but at the same time, I have to try and do the activity with her. So we start with hands and feet. We use play therapy without food at first, and then we start using also food. We carried out some tactile stimulations and also using heat stimulation on the hands and feet and also on the face. When it comes to the mouth, well, we stimulate using a soft toothbrush. And then I have a video clip that shows you that actually the parents are using the electric toothbrush that she likes a lot. Then we also use sometimes eyes or lollipop to stimulate lips. And also we actually train the vertical movement and the rotational movement, which are the two movements required for chewing. Okay, so let's start with the first video clip where you can see the play therapy and stimulation of the perioral area. As I said, she expresses herself, so she knows what she likes and what she doesn't like, and we really understand how she feels. The stimulation is made using the Meta spoon, but also using the small mirrors used by dentists. For, let's say, heat stimulation, we use a spoon, and actually we keep the spoon, for example, in the fridge, and then we use it for this stimulation. Now she likes it, as you can see. It was summer, so, you know, the cold spoon was extremely pleasant. So we start from hands. So from the peripheral areas towards the central areas. So we use this sort of gel and water solution. We start with the stimulation on the hands, and then we continue onto the mouth. You can see also the manipulation. So you can see this is just a manipulation. Well, this is a manipulation using food already. Now, this is the posture aid system that parents used also at home during meals. Now a second video clip shows oral stimulations and also stimulation of the taste of the girl. An important thing I would like to point out when it comes to Anna, but also all the other children, the important thing is that we should also always, find a way of communicating with the child and trying and understanding what the child likes. With Anna, for example, I use the smell of the product. So first we start with the smelling, and then we start and taste the product. So we explain what we offer, and we also try to always have a contrasting stimulation, so cold and hot, bitter and sweet, to have, let's say, a two-way stimulation. This is a lollipop. First, we start on the hands and then on the mouth. Anna likes, these activities. However, when she actually sees something new, well, then maybe she's kind of skeptical, but I think this is something that applies to all of us. Now, this is another video clip where you can see the importance of brushing teeth, and because oral hygiene is important. Then they started to use the electric toothbrush, and actually we found out that she loves it. So we can use it for stimulation on the palate, on the cheeks, and on the gums. And so this is very important because we managed to brush our teeth and to have a very good oral hygiene thanks to the use of this electric toothbrush. So, and you will see, really likes it. She's stimulated on different parts of the face. She activates the tongue. So actually tongue protrusion remains, but however, she really likes being, stimulated in these areas of the face. Of course, the mom is in front of her, so this is even better for her, of course. Now let's move on to the last video clip. This is the training to chewing, and as we said, Anna has always eaten creamy food since she was born, but during this year, also thanks to her family, we tried with different food. We know that she has no dysphagia when she comes to, let's say, digesting. So we tried to change food, so no longer creamy food, but having a different consistency of food. So we noticed that she accepts change. And this is the very last video clip. We offered small pieces of food, and this is actually tagliatelle, so pasta. Well, our family, Anna's family, really followed our indications when it comes to meals, and we suggested to offer separate food, so not one, let's say, plate or one dish with all food together, but separately, because so she's stimulated, she likes to try different food. So after the special training on chewing, then you will see the result.
Okay. In questo momento è alimentata sul suo passaggio.
Now you see also the posture is correct. At first, we noticed that she kept the food inside the mouth, but then swallowing is effective, and also the duration is right duration. So this meal actually took 20 to 30 minutes, so we consider it as effective.
Ok. Vado alla fine perché volevo lasciarvi un messaggio.
Now some take-home messages. So basically what we can do and with our children. So first of all, taking care of feeding problems as soon as possible. Because, well, when I first saw Anna, she was 5 months old, and we actually worked on bottle and pacifier at first. Then we should assess the oral motor abilities, we should assess the feeding, and also what is important here is a multidisciplinary approach. And of course, family should participate, take part actively in our project. So we try to involve the family of the child in order to make our intervention as effective as possible. Then with Anna, in the future, we will work on liquids because, well, she uses the bottle, but it is not really effective because actually the liquid flows out, comes out of the bottle. So we will start and try to use the sippy cup, and we will train her to actually drink water. But before, moving to water, we will use a sort of a denser water to make the move to liquid easier. Thank you.
Okay, well, we thought we were over with this. Anyway, second part or the first part of the morning, we will be talking about nutrition of children. So dysphagia represents one of the main reasons of nutritional disorders, so an altered consumption and absorption or intake of food. This is a frequent condition in PK children because this happens in almost 7 children out of 10.
Approccio all'alimentazione può dipendere.
Now, these difficulties may depend on, let's say, organic causes, for example, dysphagia, the impossibility of managing a bolus, but we also have non-organic, let's say, dysfunctions, behavioral, behavior-related problems. The typical example is the child having the same food for example, they only eat 20 or 30 types of food. They only want, white foods or, for example, orange foods, or only, let's say, crunchy foods. Children showing a lack of interest towards food. What does this depend on? Well, this means that the child in the very early phases or stages of development, he or she may have received invasive maneuvers on the oral cavity, intubation, aspiration, and then nasogastric probe feeding. So they may develop food aversion. Or children receiving, let's say, coercive feeding. I mean, they were forced to eat. I know you are responsible for, feeding your children, but quite possibly in some phases of their life, you thought that your child was not eating enough. What's the consequence? You attempted to overfeed. Maybe you don't know, you're not aware. You force him or her to eat. This has a negative impact. This is counterproductive because it may trigger food aversion. Plus, the impairment of some sensory channels. In the Anna's video, I mean, with, the offering, I mean, the lollipop, the child was sort of avoiding what was offered to her, so she just didn't want it. And this happened because one of the sensory channels, I mean, the sight of Anna, is compromised or impaired. I mean, if we do not understand what is offered as food, we just avoid it. This is why we need to work on other channels. I mean, touch, smell, and hearing. Basically, you have to, in inverted commas, we have to tell children what we are offering. So they need to touch, they need to feel, they need to smell. So no matter what the trigger is, the outcome is reduced calorie intake and the nutritional incorrect balance or unbalance. This is what we use to assess the nutritional status of your child: weight, length, stature, I mean the height. All of these values, well, basically all of these parameters have no value, but we need to have follow-up. For example, 9 kilos at 7 months of age. This means maybe nothing, but it has to be followed up longitudinally. And we need to compare this with growth curves that I'm sure you are familiar with. Now, growth depends on, calorie intake. It also depends on hormonal, genetic factors. So what about the PK child? What about his or her growth? So I'm referring to two population studies we saw before, one from the UK, the other one from the US. And in the American paper, you can see that when you deliver a PK baby, usually there's weight, length, and skull, cranial circumference, which are on high percentiles. So usually correct weight and length. This is what happens over time. The trend is actually a downtrend. Well, upon meeting or controlling 59 children, I mean the weight, the stature, but also the cranial circumference were on a low, small percentile. So this is once again a downtrend, or there's a high probability that you see a downtrend, which is what happened with Anna. Now, this is, Anna, so she was in the 50th percentile, so the perfect weight, if you will. But this is what happened to Anna. There was a decrease of weight gain. So there's, let's say, the so-called down percentile trend during the weaning period, I mean 7th month. But then it plateaued off between the 3rd and the 15th, let's say, percentile that Anna still has today. So no matter what, I mean, the calorie intake was, factors are hormonal genetic factors. I mean, they have to follow a very specific pathway. So when you have a child showing, a nutritional disorder, we have to ask two questions for families. Maybe the third question I will reveal in a second. Now, What about the calorie intake? Is this fit? I mean, is this, what about inhalation? I mean, swallowing, is this safe? Are we sure that he or she is eating? Now, if the two answers are yes or positive, we can go on with the oral, feeding. If there are no oral, let's say, skills from the child, skills are not improving, so oral feeding is not really guaranteed. For example, there was a child with pulmonary problems with plenty of inhalation, so feeding is not guaranteed. Well, in this case, we recommend a probe. And now the oral system may continue. So what can we give to improve calorie intake? Well, we have high-calorie foods or some ordinary, high-calorie products that may be added to the meals. In some cases, this is a meal replacement. They come as powder, liquid, or gel. So this kind of, these textures have to be complied with. So once again, no liquids for dysphagic children. So these are the feeding strategies we offer. We reassess the child after a while, and I realized that these maybe these assessments, these measures were not effective. And once again, I have to use a probe. So what about this kind of feeding? What is it? Well, basically, we bypass the mouth. So the mouth is not considered, let's say, to be the right, way. So I have to bypass, I have to avoid the mouth, and I can get the nasogastric probe or gastrostomy. Now, the first case, the probe will be used if the therapy is quite short. The probe cannot be left in place for too long. While if you think that we need a long-term rehab system, I need to have a gastrostomach access. There's a fistula, basically a communication between the stomach and the external surface, the outside. And I may use natural elements. I may use some, formulas that you can find, in the pharmacy. I may use syringes or a pump, so continuous feeding or bolus. This is the right system to offer water they have problems with, and drugs. Also in this case, the mouth, you don't have to leave it aside. There's enteral, feeding for the child, but anyway, oral rehabilitation never has to be forgotten. This is my second last slide. Now, if you, ask a family to move to enteral nutrition, we know it's difficult in terms of our relationship with the family. We emphasize very, technical aspects of feeding. Now, feeding is fundamental to, take calories in, to spur growth. But, in terms of nutrition, parents have all of their emotions, relationship building. Many papers, many studies, case studies say that when it comes to feeding or nutrition, well, it takes, most of the time from families. Some meals, they take hours, they take the whole day. They sort of impede, actually, the social interactions of the family. So once again, nutrition or feeding is the real pillar of, taking care of the child. Preparing the meals and then offering, food with a spoon. Mothers are so, gratified. They're so happy of doing this. And, it's a sort of a reward. So when we offer an alternative, parents do not accept easily. So we try and, do all what we can for these parents. We highlight the need of enteral, feeding. And then there may be, dysphagia, and we say, okay, we have to do something different. You will keep your attention on the baby. There will be plenty of time. You can do many, many other things for your child. It's not only a question of, feeding, because it's so important for these parents to keep, let's say, to spend time with their children, even if the feeding system will be changed. So 3 key bullets. Now, the gastrointestinal nutritional problems are very, let's say, common comorbidities in PKS. You have dysphagia, malformations, and then regurgitation and constipation. You have to assess the nutritional condition of the baby together with the oral motor skills. Just a couple of final words. Let me thank Mrs. Marani. She's attending the meeting. So together with the physiotherapist and speech therapist, they have created the dysphagia lab in Ravenna. Well, I don't have the same skills they have, but I mean, this lab has, taken care of Simone some years ago. And once again, they try and help, parents from the region facing one of the many, daily issues. Thank you so much.
Diamo ora la parola. Scusate, prima di tutto.
Okay, sorry. Let me introduce myself. My name is Luca Sangiorgi, and I'm in the medical genetics from the Rizzoli hospital in Bologna. I want to thank Samantha for this very kind invitation. It's a pleasure for me to be here with you. And she invited me a couple of months ago when we talked about Uniamo, so our Italian Rare Disease Federation meeting. Okay, let me catch up with this minor delay. Let me invite Duccio Maria Cordelli. He's from the neuropsychiatry from the S.Orsola Malpighi Hospital from Bologna. He will share with us a speech on epilepsy and neurological features of the PKS. Mr. Cordelli, please. Thank you. Okay, a couple of thank you messages. One, for, all of you, the association and the families. Thank you so much for, allowing us to be part of your family. I also would like to thank Professor Cocchi. He's the, let's say, the very, top of the, top member of this group of families. So we are working, passionately and with a high level of motivation. We want to better understand this syndrome and all of its consequences. Okay, this is my, agenda, if you will, 3 key points of my presentation. Now, my colleague, Emilia Ricci, will be talking about the papers already published on this features on the phenotype. There will be a proactive part of my presentation. What we think we can do to, implement all of our knowledge together with some hands-on practical, data on the neurological phenotype. Okay, let me give the floor to Mrs. Ricci. She works with us in a hospital, and she's a researcher on neurological phenotypes of rare diseases. Emilia, the floor is yours. Good morning, everyone. Thank you so much for inviting me here in Cervia this morning. Now, as for the literature review, I've broken down my presentation in 3 key bullet points. Epilepsy. I will go through a review of the main reports. We will go through them together. I will do the same in terms of the neuroimaging studies and the neurocognitive and behavioral profile. So, first of all, let me make the point on the state of the art. So all what we know so far. Now, in terms of epilepsy, this paper is an Italian one published back in 2012. It was conducted on 13 patients. So what we see is that the most frequently, let's say, most frequent is basically epileptic spasms at the onset, so early onset, but also later, with focal crisis or seizures and myoclonic seizures. This is what we saw on 2 patients out of 13, is photosensitivity. As for pharmacological therapies, this is the distinctions that we have to have. So drugs at the onset and drugs in terms of follow-up. The 2 main drugs are vibragrudin that you use at the very onset. So if it is it's effective when used, individually, then you have the valproic acid. Once again, it seems to be effective in most cases. Now, as for the EEG abnormalities, well, I don't want to give you too many technical details, but the main things are the following. The basic background activity in terms of onset, well, this is disorganized. In many patients, there's a slowed down basic activity. The paroxystical abnormalities are very frequent at the onset, while in the follow-up time, they usually disappear. There's something we don't know. I mean, how long the follow-up is or what the age is at the end of the follow-up. So we are not able yet to really understand if this is age-dependent. Let me show you some of the, pictures of the spasms that you can see here. You can see here the muscles. This corresponds to a sort of a boost or the action, and this abnormality here, this is something that we can see in terms of the brain electrical activity. While here you have 2 non-crisis results, where you can see abnormal discharges at the onset of the disease. This is another paper. In this case, the population was represented by a larger number of patients, but in terms of the trial design, some data are missing versus the previous one. So we can see that we are a little skeptical. I mean, the seizures or the crisis, which is the most frequent one, unlike the previous one, are the myoclonic seizures. Then you have the generalized, the convulsive seizures, but this may also be focal seizures, and they only generalize later on and then back to epilepsy or epileptic spasms. As for the therapy, in this case, we don't have the therapy effectiveness timing. I mean, there's no difference between onset and the follow-up. It's really difficult to draw conclusions that are, reliable conclusions. Now, what we see here is a higher level of effectiveness in this, sample or population from levetiracetam. Pharmacological associations are not clear, including the type of seizure. We don't know exactly when this drug is effective. Another point which is worth noting, in more than 50% of patients, we have major severe epilepsy. I mean, it requires the change, the modification of the pharmacological therapy at least twice. So this is also another important aspect. This is the 3rd and last trial. 2 cases are described in depth. There's also a review of the electroclinical aspects we saw so far. This trial was carried out in 2010. Back to epileptic spasms as most frequent seizure, and then focal seizures. And then we see the disappearance of generalized convulsive spasms that were overrepresented at the onset. This is also worth noting. Focal seizures that we saw in the 2 previous trial. There's one like staring. Now, staring means that there's a motor arrest, so the child sort of, freezes. And I need to share this with you because maybe this is, misrecognized or difficult to identify. So EEG abnormalities, once again, here we cannot, get important information. You can see here two very common patterns. You can see here so-called periodical spasms because, you can see here that the time difference is always the same, so it's sort of very rhythmic. And on the right, you can see here photosensitivity. In this trial, they say that one patient was photosensitive no matter what the frequency was. So every time he or she saw flash during the EEG test, and you can see here many other articles or trials, but once again, we don't have anything new, let's say, out of these papers. Let me try and summarize this first part of the presentation. There's epilepsy in most PK patients, even if we don't have consistent, data. Anyway, between 50 and 70% of PK patients suffer from epilepsy, and the most frequently epilepsies are epileptic crises at the onset and myoclonic seizures, followed by focal seizures, and only on a later stage they may become generalized. As for the most appropriate drug therapy, well, we don't have complete data. Anyway, we know that vigabatrin is used. This is for spasm control at the onset in the epilepsy. Valproic acid, that's another drug we find often seemingly effective, emiracetam. Now, emiracetam is a very effective drug on photosensitivity, so there may be a link, a connection between photosensitivity that patients show on the one side and the effectiveness of the drug on the other. Anyway, plenty of questions are still unanswered. I mean, what are the most frequent crises, for example, or seizures? Once again, we don't have consistent data, and we also have to say that quite often we see a motor, manifestation of epilepsy, which is not to be considered as, myoclonic spasm, especially if you don't have any enough data on one specific patient. There's another question. Do we have some factors favoring, seizures? And again, another question, what about photosensitivity? Is this confirmed or not? And again, is there any link between epilepsy severity and possible brain malformation? And another question, is there a genotype-phenotype link? Now, plenty of questions that we keep asking, and the main aim is that, well, we have to know the main features of epilepsy. So if we are able to do this, we will create most effective therapeutic strategies, more effective than today's. And we need a specific method or design in order to really, get as much data as possible. As for neuroimaging, this is the 13-patient trial from the Italian team. So in some cases, we have an ordinary resonance, a normal magnetic resonance in 4 patients. In other cases, as for the gray matter, there's a diffused cortical atrophy with frontal prevalence. In other cases, there's ventricular, dilatation. And we also have one patient with the corpus callosum hyperplasia. So this is to make the point on some neuroimaging aspects. On the left, there's a list of all what was described so far, what you can find in the literature. Then they describe 2 adult patients for whom they saw different alterations on the gray matter. Very similar, so lacunar infarction, for example, in the second patient, there's atrophy of infratentorial structures. You can see here some pictures. You see the, open ventricles, dilated ventricles. This is the corpus callosum. I mean, usually it's thicker, while here it's thinner. And you have atrophy of the infratentorial structures. Let me try and, draw your attention on neuroimaging. There's a high variability level. I mean, resonance may look or be normal, but we can also have abnormalities on the gray matter. You can see here the cortical development abnormalities breaking down depending on when they take place. So migration, and then you can also hear the heterothopy, pachygyria, lissencephaly, and other abnormalities. The most frequent one is the diffused cortical atrophy and ventricular dilatation. As for the white matter, you have corpus callosum abnormalities together with dysmyelinization. And also in this case, I need to repeat that we need special studies. I mean, the study design should be a little more specific. As for the neurocognitive profile, unfortunately, we don't have much data. And this is a trial on 16 patients that have used Vinland. I mean, it's basically a measurement or assessment scales, which are built based on questions for parents, and so this scale works on the adaptive functions of children. So once again, let me skip, figures or numbers or technical details. I'd like to draw your attention on the fact that all of the scales, assessment scales we have, tests and testing systems for our children, we are not 100% sure this is what we need. I mean, these assessment scales are very sort of random on a non-well-defined population. So maybe they are not really, targeted or aimed at really understanding the kind of neurosensory impairment we have for PK children. I mean, this is based, if you will, on different processes. So our average population is taken into account, not PK children. There's another important piece of data. There's a major phenotypical variability. So it's true that in most patients, this trial says that there's no speech and there's no autonomous gait. But at the same time, we have patients that manage to express themselves. So they speak and they do walk, or they have deambulation. This is my last slide on the behavioral profile. This is also a questionnaire that we asked to fill out with 5 sub-scales. So we see stereotypical behaviors. They are described as lethargic. There are plenty of questions here. So how does sleep work for these patients? Because, sleep questionnaires have not been shared with all parents or families. Anyway, they apparently show sleep disorders, in some cases sleep apnea. And this has an impact on this, lethargy or lethargic, attitude we see during the day. This is also something we see often. I mean, there's an avoidance, attitude towards a tactile stimuli. For example, offering a toy or an object because maybe they find it difficult to understand exactly what is coming from, for example, the hands of the parents. So once again, unanswered questions. What are then the best assessment tools? So are we using the right tools? Is there a correlation between the cognitive profile and the severity of epilepsy? In the literature, all the patients described are the so-called high functioning, but they have no epilepsy. So what about the direct role of epilepsy. Is there a correlation between the neurocognitive profile and the brain malformations? And what about sleep disorders and their consequence on behavior? Do we have specific pharmacological therapies, for example, to fight against epilepsy? So this may have an indirect, consequence on behavior. Once again, what we need is specially conceived, targeted trials to answer these questions. Back to Dr. Cortelli. Thank you. Finisco that.
Cerchiamo di capire.
So let me tell you what we can do, considering all of this, information. So this is what we would like to do thanks to our association. We would like to carry out a trial on the neurological phenotype of these PK children. And as Emilia said in her speech, we would like to define the features of epilepsy, frequent seizures, a response to the anti-epilepsy drugs. It's fundamental. I mean, we need to understand what the best drugs are in this situation. And we need to understand the evolution thanks to EEG exams. This is something that we don't see in the literature. We have to do this also for the children that have no seizures. I mean, we need to understand more about their neurology. And the same happens in terms of the main features of the brain malformations. Now, we want to do this to define features. At the same time, we would like to better understand how neurology works in the PK syndrome. So we'd like to correlate all of these pieces of information: epilepsy, EEG, plus malformations of the brain, if present, and if possible, genotype, which is much more complex. I mean, the key genetic features of these children, so that we can really have a much brighter, deeper framework, so we can really understand why some things happen. And the main aim is having, some very practical, tangible, situations. I mean, we would like to react in the best and most effective way possible. All of this is important because we need to improve our general knowledge on this syndrome. We don't know enough because we want to improve the general management of this disease, including follow-up management. So, for example, what is the best way, the most useful way to take care of these children? Is it possible to define groups of children to be, let's say, divided in clusters? This afternoon, there will be a speech on the follow-up of these children, and including the daily domestic, if you will, service. I mean, the right therapies we can deliver at home, including expectations that we may have out of, very practical, tangible, recommendations to face daily life. So we need to organize a harmonized trial with, as many children as possible. So this trial will be able to deliver great outcomes. So how can we do all this? How to reach all of these targets? Well, first of all, we need to collect as much clinical data as possible. So clinical history, neurological history of the children. We need to use EEG and MRI, so magnetic resonance of the brain of children. We have to do this, otherwise the system wouldn't work. I mean, what we need is a multidisciplinary team. So we need a genetic expert, we need a neurologist cooperating with us, child and even non-child and neurologist being able to assess the results, a neuroradiologist, and you can see here, this is bold, we need the association of our families. I mean, families that need to cooperate with us to have, the best trial ever. So they are one key pillar of the team. So what can families do? Well, they have to give us the EEG tests. So, those, performed in the past, magnetic resonance outcomes, and the neurocognitive assessments. As much as they can. I know it may be difficult, this has, no impact on the new examinations to be carried out, but it allows us to have important data to start assessing all of the phenotypes involved, especially in specific cases. So we may have a specific, centralized assessment in a center of excellence that may be our own center of rare diseases in Bologna. As for the, medical doctors, caregivers in general are the other main pillar. They can send us, documentation under a different perspective. We can be a little bit more technical with doctors or with the, let's say, coordinating center where, research is carried out. So, these, technical specialists are, once again, one of the key parts or pillars of our trial. So I have some, practical examples, some tangible data. Now, I have some data to share with you on the very first initial assessments of the phenotype. There's one, example of something that, goes through the whole trial. Mrs. Ritchie was talking about photosensitivity. This is one of the trends we saw in some children with PK. So they have some myoclonic, seizures as a consequence of light. I have a short clip to show you. I hope you can see as soon as the flash comes. So you can see the presence of, minor seizures, also for, let's say, relatively small flashes. I remember the child, every time we switched on the light at home, she had, seizures. Now, this is, I understand it's a big issue, for the child and in his or her daily life, including his or her family. So we need to understand exactly what happens. Is photosensitivity an issue or not? It's a key question for us. So, and if it is, of course, we have to use specific drugs, including doing some adjustments. So instead of having, switches, we may have dimmers, so you can dim the light up and down. And it's a very simple example. So you just have to understand, the neurological situation, and then based on this, you will, adjust the little things at home. Very, simple, practical, daily life issues. You can see here, from the, let's say, the epilepsy or epileptic nature of the seizures you've just seen. Okay, let me draw some conclusions about our current knowledge. Now, seizures or epileptic seizures may be one of the elements to be included into PKS. Some types of seizures are more frequent, but we don't know why, how. There's a difference between children. We don't have the correlation between the quantity of seizures, the cognitive framework, behavioral disorders, and you know that in everyday life this is remarkably important. We know that the valproic acid, I shouldn't say that because of course you have commercial names, Defects and Keppra here in Italy. These are the most widely used drugs, but we don't know in which patients, what the best drug is considering the conditions and the situation of our patients. Once again, we have to be very practical. We need to improve our knowledge, to enhance all of the things we know, just to give something which is more and more appropriate for these children. Maybe there's a reduction of seizures while time goes by, or maybe if we don't have now seizures, may our children develop them? We just don't know. I mean, pharmacological therapies, I mean, the most effective therapies, we don't know exactly how they work and how much they work. So we know that, of course, we need to improve knowledge in order to manage at best all of the neurological issues. Thank you so much for your attention.
E quindi un vivo ringraziamento a Duccio.
Thank you very much to Professor Cordelli and Mrs. Ricci for the comprehensive and exhaustive presentation, also given the problems, in particular when it comes to neurocognitive features and also behavioral disorders and epilepsy. We, in Bologna, we are setting up a center dedicated to neuroepileptic assessment of the children. The Bologna Center is already involved in the study of other rare diseases, so this could also become a center for PKS assessment and study. Now it is a great pleasure to give the floor to Luca Sangiorgi, who is the responsible for genetics at the Rizzoli Hospital in Bologna, and his presentation is about the skeletal involvement in the PKS. Thank you so much. Thank you for the organizers. My presentation is extremely short, and it is about the skeletal involvement or PKS. Unfortunately, there is not so much information. There is not so much information, and there are no studies. So we tried and looked for papers or studies in literature. And so I will start with the presentation, and after that, a short video clip of a European initiative, which is the European Reference Network. The video clip is about rare diseases, in particular skeletal rare diseases, because I'm part of such a European network. However, there are other networks for malformation syndromes and for neurological diseases. And these networks could be, let's say, our home in order to, let's say, put together patients and perform the right assessments in order to obtain answers to our questions, because sometimes we do not have enough patients for studies. Okay, so going back to my presentation. As I said, in literature, there are not so many articles and papers. So it is kind of rare, but not so much. So the skeletal involvement in the PKS is proved, and there is some evidence about that. So these are the most common problems. So polydactyly, which is quite frequent in literature, joint contractures, sometimes hip dislocation, and short limbs. In the study carried out in Philadelphia by the Children's Hospital, they confirmed that skeletal features are present in almost 40% of the patients analyzed. However, there is no specific characterization of the patients. The two studies have something in common. So they noticed an abnormal growth pattern. So there is a sort of a growth acceleration in the prenatal phase, so prenatal overgrowth, and then a decline of growth in the postnatal period. And so actually the centiles actually decrease over time. I personally had the opportunity to meet Sheila and Gen Nishimura, who published this interesting article in 2012. They actually followed 3 patients, and they found 3 main features. First of all, a delayed ossification in the vertebra, and often we find scoliosis in PKS patients. Then alteration in the growth of pubic bones, and this actually results in the hip dislocation. And also the problem of ribs. We mentioned the diaphragmatic problems and troubles. Then there is also, when it comes to long bones, in particular for the femur, there is something which is characteristic when it comes to large metaphysis. And also there is a delay in the ossification of the axial skeleton. We don't know if this is a consequence of, for example, feeding problems, or if this comes first, if there is a number of causes determining this or factors determining this. Now, here you can see some of the features I have mentioned. So, poor ossification, and actually, in this case, there is no ossification at all. Then ossification resumes after some time. So we follow patients for some time, but there are some situations, for example, when it comes to proximal fibula markedly hyperplastic. So there are some factors that actually do not change over time. And this is what I mentioned before for the vertebral bodies. This is the ovoid-shaped vertebral bodies during early infancy. For the distal phalanges, we found a mild hyperplasia and also occipital synchondrosis. So now to conclude, we can say that there is a specific pattern for the skeletal maturation, but we do not know what are the factors or the causes of these specific patterns. There might be joint factors, and also in this case, an enlarged study of these aspects could be extremely useful, and in particular when it comes to the prenatal features, that would be also an important study. So unfortunately, as I said, we do not have many information, so these are just a few insights about skeletal maturation. Now, just a few words about our office that follows patients. And if you have 5 minutes, I have a short video clip to share with you that actually talks about the networks I mentioned, and so what such networks could offer to PKS as well. Thank you.
In 2017, over 900 highly specialized medical teams from all over Europe joined their forces in the European reference networks. Together, they tackle complex or rare diseases. This new European initiative allows doctors to share their knowledge, data and resources in virtual networks, for instance, for the treatment of complex bone disorders.
I'm Luca Sangiorgi. I'm the head of the Rizzoli Orthopedic Institute. And I'm also the coordinator of Bond ERN, that is the ERN for rare bone disorder that is taking care of patients with this kind of problem in 38 centers spread in 10 of the European countries. Currently, we don't have an homogeneous treatment for this patient, meaning that a patient, according to the different country where he is treated, could get a different treatment. And that's not fair. The patient shouldn't travel, but the information should travel. And so one of the most important issues is to establish good interoperability between all these different centers in order to set up something that could benefit the patient.
Sono Elisa Ferrarini, ho quasi 30 anni, ho l'ossogenesi imperfetta e abito ad Alessandria, in Italia. Ho sempre saputo di avere l'ossogenesi imperfetta perché me l'hanno diagnosticata da piccola e quindi ho sempre vissuto con questo disturbo. L'effetto più evidente dell'ossogenesi imperfetta sono le ossa fragili, quindi ho sempre saputo che non potevo cadere, non potevo giocare come gli altri bambini perché se cado mi rompo qualche cosa. E quindi l'effetto più evidente è che devo stare attenta quando faccio un gradino, quando piove, quando nevica, quando c'è una superficie scivolosa.
European Reference Network can answer to the specific need of the patient, like having the right diagnosis at the right time. For instance, Elisa never got a molecular testing so far, and she is 30 years old. European Reference Network could answer to their needs to have a more appropriate diagnosis in the right time. Currently, it takes 7 to 10 years for a patient with rare disease to get a diagnosis. We really hope to be able to shorten that at least half of the time. One of the major points is to have a strong interaction between ERN in order to respond to those patients that are bridging between different ERNs, meaning that they have symptoms that could be part of the ERN, like bone, and symptoms that could be part of the endocrine ERN or of the metabolic ERN. What we would like to do is try to merge data that are coming from different sources in order to get a better picture of the disease, a picture that could be reproducible in all are part of the ERN, and try to get important information for the diagnosis, the follow-up and the treatment of the patient.
Quello che mi aspetto dalla European Reference Network è che ci sia più ricerca, quindi anche per le persone, per i bambini che vengono diagnosticati, che ci sia più ricerca per cercare di migliorare la qualità di vita delle persone che sono affette da ossogenesi imperfetta ed altri disturbi rari. Spero che vengano diagnosticate prima, che ci sia più ricerca, che ci siano più cure disponibili per queste malattie rare, che spesso vengono diagnosticate troppo tardi e quindi i pazienti fanno cure che effettivamente non sono loro utili perché appunto si pensa di curare la malattia sbagliata.
Probably we will be able also to show to the medical world that rare disorders are not so rare and not so peculiar. We can show that the treatment that is set up for rare disorder could be also applied to more spread disorders. And I think that this is going to lead to the point that ERN could be really a revolution in the way in which healthcare is provided to the patient.
Ecco, volevo giusto dirvi che
I wanted to tell you that the PKS is part of Itaca, so intellectual disabilities and rare intellectual disabilities. So we are part of network, and we hope that we can work hard together with these networks. I would like to thank Professor Sangiorgi as well. Now we are moving on to ophthalmology features, and Professor Salazzi is specialized in ophthalmology, and he works in at the hospital La Nostra Famiglia in Lecce. Now, just a couple of minutes. So in the meantime, if you have questions, we are glad to answer. Now, our networks have reference centers. So every country has sort of a reference network. For Itaca, I think there is one center in Rome, so the Bambin Gesù Hospital, and also in Bologna. We will meet soon in Brussels, and what we're trying to do is setting up a sort of exchange system in order to share diagnostics, and so by means of the reference centers, for example, in Rome and Bologna. For example, in our network, we have 7 reference centers. And so our goal is actually sharing information, diagnostic information, and requests and problem about this. On the 16th of October in Rome, at the ministry headquarters, well, the networks will be launched, and hopefully our minister will be present. And so all the centers will be present. From that time on the website of the Italian Ministry of Health, you will have all the centers. So on the website, you will have a list of the centers. So that day, so the 16th of September, will be the kickoff meeting in Italy, and so the network will be formalized all over Europe. Now, I give the floor to Roberto Salasi. Good morning. I would like, first of all, to thank you for inviting me, and I also actually would like to greet you on behalf of Professor Ranieri, who has been taking care of PKS cases. Personally, I work at the IMEDIA Center, which is a rehabilitation center, and also Dr. Bogazzi, the head of the surgery ward, where basically the patients were hospitalized. Personally, I'm in charge of the ophthalmology ward, and in particular when it comes to pediatric ophthalmology. Now, I will skip the main features of the PKS, which has been described, but now, well, when it comes to ophthalmology, we do not have many information about PKS. This is just a recap table. So first of all, the adnexy and the orbital areas are involved, such as eyelids and eyebrows, and ptosis is quite evident. Now, when it comes to the front or anterior segment, we have noticed cataracts, or, for example, strabisms, or squint, so both convergent and divergent, and nystagmus, which is a sort of a eye movement, so eyes moving like wipers, windscreen wipers, and they do indicate, however, hypervision, so vision impairment. In literature, we do not have many information, as I said. So what are the main features or the distinctive features? Well, first of all, hypertelorism, strabismus, which do not imply vision impairment, ptosis, nystagmus, which on the contrary might cause it, and also hyperpigmentation. Now, we analyzed 7 clinical cases, so 7 patients who were diagnosed correctly. So these are reliable, certain cases. And we studied the ophthalmology features of these 7 patients. Now, I know this table is not easy to understand. However, first of all, it was not possible to measure the sight, and also we couldn't perform the Teller's test, which is the very simple test that you can actually perform with babies, and basically is looking at letters. But even through Teller, we couldn't assess the actually the condition. Strabismus was present. Actually, divergent was the most common. When it comes to nystagmus, 6 out of 7 had it. Nystagmus indicates actually visual impairment, and the lack of coordination. So this is a very general term that indicates the alteration of psychotic reflexes. So person cannot follow an object. So if I show an object to the person, so a micro-target, and they move it, for example, a 6-month or 8-month-old baby usually look at the object. So in this case, we analyze also the environment investigation by the baby. Every time a baby enters a new environment, he or she looks around. Every time something is offered, so the baby is curious if it is a microlight. So the type of behavior of the child when it comes to the eye movement when tests are performed. And all the subjects had lack of coordination, so they do not stare at the object, they do not follow the object. And they do not explore or investigate the environment in a correct way. They all had normal optical nerve, and when it comes to retina, some had hyperpigmentation, but it was not significant in my opinion. Whereas we noticed some alteration when it comes to sight. So basically this indicates the connection between the stimulus and the occipital cortex. And so if there is no connection, this means that there is a visual impairment. So I looked at the fundus oculi, which has the right color, so sort of a pink color, but so it looks normal. But when there is a stimulus, it does not respond. So this means that there is something that doesn't work behind the optical nerve. So this shows a normal, and the other is the visual impaired eye. So let's have a look at the imaging, and the physician before me actually confirmed this. Now, there are, in these 3 patients, damages in the white matter, depletion of the white matter, which means that since the optical radiation actually moves next to the ventricles, so, and this is white matter, basically all this translates into visual impairment. So the optical nerve looks okay, so no problem, but actually there is a damage. So based on the imaging, unfortunately only 3 cases, as I said, only 3 patients. Based on the fact that a specific damage was detected through the imaging, and also based on the lack of coordination when it comes to the eye motor ability, and so and also we had a sort of an alteration. So we actually resulted in a cerebral visual impairment. So visual impairment, which has been recently described and it is quite severe. So we can't actually measure sight, but however, we know that there is a visual impairment. So the conclusion of our study is that we do have nystagmus, lack of coordination, exodeviation. So all these elements actually make us think that they might have a cerebral visual impairment. So these are the conclusions of our study. We should actually have done further studies because unfortunately, well, our center is a rehabilitation center, so we didn't have sometimes very comprehensive records. So we actually should have all the tests, we should have the imaging and also an ophthalmology assessment of the patient. Because we could also have the CVI when it comes to the PKS syndrome. So the CVI is kind of weird. I mean, of course, CVI stands for cerebral visual impairment, and we have to go back to 1982 when a scholar in the United States described for the first time the CVI, which is a severe condition, and you will see that this is one of the first causes of hypervision in children. But actually, it was only in 1982 that this condition was recognized and identified. And why is that? Because unfortunately, all the patients have disabilities, so it is difficult to measure the functions, and so basically we only say, you know, there is a vision impairment, but we cannot characterize it. However, we should measure the function, the visual function, and that was investigated by Good, so the first physician, first scholar who actually said that, well, we know what the cerebral visual impairment is, and we also know cortical blindness. You might have damage in the cortex, so becomes blind, the person becomes blind, but the fundus oculi is normal. We do have a clinical characterization of the cortical blindness, but we can't find this in children because in children the behavior is different. The plasticity of the cerebral system is such that the damage is present, but the child behaves differently. And so this is why there is a different condition. This is our visual channel, and actually the damage is here in this area, up until the cortex. So we mentioned diffused cortical damages, so they might also affect sight, which is in the third posterior part of the brain. Now, as I said, it was only 1982 that the CVI was first described, but personally, I remember when I was talking to my professor, actually, he was saying, you know, we have to study CVI, and he said, well, but what CVI is? Does it exist? And I said, yes, it exists, and there are papers and articles. And then later on, we conducted a number of studies, but at first, I mean, we knew about cortical vision impairment, but it was later on that we found that children behave differently if compared to adults. And, well, we started to investigate it. So this is a sort of a hidden damage. However, this is one of the main causes of hypervision in children. This is a study by Lancet, and CVI is considered as the first cause of blindness, of cerebral blindness in children. Well, when it comes to the etiology of CVI, ischemic, epilepsy, but there are also, so many of them, but there are also malformations and also some forms related to epilepsy. This is not related to to PKS, but however, most of patients with CVI also have severe disabilities, intellectual disabilities. So when the damage is present, there are alterations which are different, completely different, because basically we have a damage, a reabsorption, and a congenital malformation, whereas from the second and third quarter, we do have damage, which is what we find in our subject, in our patient. Or we could also find cortical damage, so encephalomalacia. What do patients have? Well, an hypervision, well, this can be measured. These are the patients with CVI, but it is roughly 1/10. They do have complimentary defects, which is kind of very difficult to measure it. However, it is extremely difficult to identify complimentary defects. Strabismus, nystagmus, and oculomotor disorders and atrophia. This is actually something found in patients where occipital cells die, and actually this continues up to the retina cells that cause the atrophy of the optical nerve. This is the ocular motor dysfunction. So as I said, the exploration of the environment is impaired. The impossibility to stare at things, the saccade initiation failure. Basically, in this case, you can't modulate it, so the object appears in a map, and actually maybe a person enters the room, so something happened. So these phenomena are quite frequent. In this case, basically, there is an impossibility to generate the saccade. So what happens? Well, something appears on the right-hand side, but you can't direct your eyes to that direction. So you have to move the head with a very slow movement, sometimes starting from the opposite direction, but it takes 2 or 3 seconds to reach the direction that you wanted to look at. So you see what is there, but it takes like 2 or 3 seconds instead of 1 microsecond, because saccade is an extremely fast movement. So this is the impossibility to investigate, to explore the environment. Then there's smooth pursuit. This is the slow pursuit of the objects. Well, this is actually something that requires all the cortical areas, also the front occipital areas. So the smooth pursuit is actually impossible if you have a diffused cortical damage, because it requires for the integration of too many circuits. Paroxysmal ocular disorders, and so I think that this is it for my presentation. So my personal, well, it's not a suggestion, it's just a recommendation. It would be interesting to look at all the imaging for all the patients and also the assessment of the optical nerve to see if they are affected by CVI or not, because as I said, well, there are patients with a CVI which is very mild to severe. So sometimes we cannot see it because the severity is variable. Thank you.
Bene, ringraziamo il dottor Salati, Roberto Salati, perché in effetti...
Thank you so much, Professor Salati. Now, this is great food for thought, and it spurs cooperation and teamwork. I'm sure this, is, say, intertwined directly with our own, actions and work in order to really better understand this syndrome. Let me now give the floor to Professor Silvia Alboresi. She's from the Rehab Unit, Severe Disabilities Developmental Age from Reggio Emilia. She will be talking about the rehab treatment of PKS. Good morning. Thank you very much for this very kind invitation. Now, for me, this is a great opportunity for, let's say, re-educators on rehab specialists. First of all, we can meet other, partners. We can really talk about the rehab, re-education, treatment, and physical therapy, all at once. I mean, it's, commonly used words and actions also in other, areas of our profession. So I'd like to, touch upon these points, and I will try and, clarify on what re-educators do. Now, this is something you probably know, but, I cannot skip this. I mean, I have to talk about clinical variability because as a rehab specialist or re-educator, we have to talk about children that have, a favorable positive prognosis for gait or standing position. But we also have to consider those children for whom this prognosis is a bad one. This is a major challenge to be taken up for re-educators and clinicians in general. So it's kind of difficult to, share with you a general overview that, meets the needs of diverse patients. Re-education, rehabilitation are strictly customized, child-centric. Now, the guidelines of NORD, National Organization for Rare Disorders 2016, as was mentioned in one of the speeches this morning, most children are not able to have an independent, autonomous gait. And this is included in, the case studies carried out. Anyway, this is, rare pathology. In a very humble way, I try and be as humble and honestly. So this is the number of cases from my center in Reggio Emilia, 5 cases. So of course, this is not, statistically significant, and I cannot say I am an expert in this syndrome. Anyway, what we do is taking care of severe disabilities or infant disabilities, and this is, a sector we are very familiar with. I'm not going to go through once again of, all of the problems concerning the syndrome, but I'd like you to see this, let's say, from my own perspective. For example, if I see hip displacement, if I see a severe developmental scoliosis, early onset, fast-paced, well, our reaction is, what can I do about these functions? So that deformity or that deformation has an impact on the development of that child. How can I verticalize the child? How can I offer a sort of a displacement, for example, when we have a displaced hip? Or again, seizures. And now seizures, we, heard, the previous speaker, talking about epilepsy and convulsions. So this is important for us as educators, because when a child rebuilds a function, manipulation, language, gait, standing, posture, seating postures, it is just like basically creating something brand new. So as soon as you have, seizure, and in some cases, these seizures may be very severe with apnea or desaturation. Well, this, seizure is just like, flood water, ravaging, a crop in a field. So this is what we have to imagine when we want to rebuild, functions, or, for example, restoring that field after the flood. So back to severe sensory aspects. For example, the impaired hearing and impaired visual acuity. So, visual functions may have an impact on the interactions of that child with objects, the way he or she will be interacting with space around him or her. Now, talking about the treatment, let me share with you these statements from the NORD, so the National Organization for Rare Disorders website, where they talk about treatments. They say that there's no specific therapy available for PK syndrome children. And by this, they mean a real cure. I mean, let's say to heal, so to say, the genetic alteration. And PK children may take advantage from early intervention or special education. Third and last point, other treatments are symptomatic, and so this works on the symptom, for example, on scoliosis, or they just give support. So they are supportive treatments, and I believe this is true. You can see here I have highlighted, some keywords: therapy, intervention, education, and treatment. This is not, let's say, meaningful enough. This is not specific enough. So we need to clarify the meaning of this for families, because when we talk about, for example, re-education or rehabilitation, this is a complex process inside which you have sort of, subsets that you can see here. We also have the real re-education of function. We have education and support or assistance. These areas are totally different. This is not rehab. They are within, if you will, the big category of rehabilitation. But when you talk about physical therapists, basically this is one of the subsets. The re-education chapter, if you will. Early intervention, I don't really like this, because when you talk about, rehab or physical therapy treatment, when it is very early, this may be risky. When should we start treatment? Now, I have to say that taking care of the child, this has to be early. So as soon as, he or she is out of the neonatology ward, so we start, let's say, working on that child. We take care. But the real treatment, and even the physical therapist, when is the right time? When should we start? Well, as soon as the child is tolerating, for example, well-being, and this depends on many, many different, conditions. So if the child is fine, he or she is, let's say, available to open up to the environment. If there's a disease or difficulties, well, the operator or the educator may be a hindrance for the child. So if you offer something bad to the child, well, the child, moves back. He or she closes up, if you will. So, it's already sort of difficult for him or her to, let's say, get acquainted with the rest of the world because of hearing and sight impairment. I'll be back in special education on 1 second, and I will describe the specific context you have to have specific education in. So what is rehabilitation? It's a very overarching general term, quite complex, by the way. So we want to have this complex process aiming at promoting the best quality of life possible for the child and his or her family. Let me highlight a couple of meanings that you have here, the child and the family. So we have both, well, we have an individual and a group of persons and the family. Just think of well-being or quality of life. This well-being has to be shared. The child on the one side and the family on the other. I frequently ask the question to re-educators, how many postural changes should we have from that child, for example, throughout one day, including sleep, night sleep? Well, technical response should be 1 every hour. Anyway, this is the well-being of the child, but we also have to consider well-being, or the so-called QOL, or quality of life of that family. Because if you change position once every hour, this may not be compatible with, you know, the well-being of his or her family. Re-educators have to be very focused. So what's the right answer to this question? Maybe 2 or 3 at best. And this means, you know, breaking, interrupting sleep. This means that the parent will be tired because, I mean, if you have these sort of, you know, discontinuations happening too often. Now, re-education is one of the chapters or subset of rehabilitation. So in this case, we have physical therapists, physiatricians, orthopedists, and you know, all the specialties involved. Now the key target here is the development and the improvement, but also the creation of the so-called adaptive functions. Adaptive functions, unlike survival functions, for example, swallowing or respiration. Now, these are difficult to re-educate because they look like, I mean, they are the same in every person. Let's say that in this case, it's difficult to change those patterns. What can be modified is the adaptive functions. For example, the control of the head, control of the trunk, standing position, and gait if possible, or the use of upper limbs, manipulations, or handling things. So let's say interacting with the rest of the world. So the key task of re-education for PKS children means helping them build, or helping them build their own adaptive functions. This is the, let's say, wait a second, this is pathological function. So all the methods reminding us of the ordinary method. So now sitting position, and then, crawling, and then standing position. Well, this is something that we do no longer use. I mean, we consider the child will go through his or her own development, pathway that we have to be familiar with, so they can reach their best level of constructing or building all of these functions. Now, adaptive also means the aim that we have. So we have to have an objective. So handling or manipulating to do what? Well, to improve interactions or to change the world around us. For example, we move something provided that, children need to move. I mean, if there's no need, it's impossible to get to that function. Now, re-education, and once again, this is a key point highlighted by re-educators. This is a discontinuous process. It is not seamless. It starts, it ends. Of course, it can be discontinued and then continued or, restored. But, the care is seamless. Re-educating functions is not. We start as early as we can, so we have to tolerate children. So this is what I said before, quality of life or well-being, so they accept what we offer. But then we stop when we are no longer able to change something. I mean, we may have worked on manipulation of objects or gait for the right time. I mean, maybe months, maybe years, up to 6 or 7 years. Now, after 6 or 7 years of physical therapy, if we are not able to build that function, now this is not bad physical therapist. I mean, the child is not to be blamed. I mean, something just didn't work. We have to say that that tool is not able to produce or to trigger any change. So it is not therapeutical. And to be therapeutical, I have to be able to show that I have produced a change in that child, maybe a minor one, but there was a change, something that can be measured, something which is, objective and maintained. So at the end of the physical therapy, the change stays, I mean, is maintained. Okay, we may face this point during the Q&A session. Education is a different thing. This also has to do with health operators or caregivers. I'm talking about, once again, educators and teachers. What's the objective of education? We prepare, if you will, the child to get into the social context. So, crash, and then preschool, school, and so on and so forth. So, this is an incredible thing we have in Italy. I mean, school is open to all. We have mainstream education written into the Italian constitutional charter. I mean, we don't say, well, there are some exceptions, open, but no way. It's open to everyone. So based on this constitution, we have all the services available so that children, disabled children, can, let's say, take part in a mainstream system. We don't have any special education in Italy, fortunately so. This is my opinion. And we have two different roles, two functions. On the one side, we need to, educate the disabled child. On the one side, we have to educate the rest of the society to the disability of the child. So it's a two-way system. In terms of support or assistance, if you will, this is the fourth and last, let's say, subset of rehabilitation, especially in those cases where the disability is very severe. Well, maybe the educational targets are a little constrained. You can see here plenty of the jargon, I mean, the language we saw before, but this has a very specific meaning. I mean, if the change is very limited, functions are limited, well, what is fundamental is support or assistance, which is partly generated by healthcare operators or caregivers, including plenty of maneuvers, for example, personal hygiene, postural hygiene, and the physical therapist cannot do all of these things. So this is included into a long pathway, which is what families have to take into account, including, for example, nurses. These actions are very frequent. So once again, the physical therapist cannot do all of this. It's a major intervention. This is the real care. Now, the cure is different. I mean, even if a disease is incurable, well, you can do something. I mean, care is possible. And the objectives are very different. So assistance or support is crucial. It's a very wide, deep intervention system. And once again, this is absolutely seamless. So it goes through the whole pathway, from birth to adulthood, or even, to the elderly age. There's another point. What are the prerequisites? I mean, the key, the fundamental, if you will, the building blocks of re-education. So when we offer, the proper re-education, so manipulation, standing position, gait with aids or orthesis, well, before defining what we can change in that PKS child, well, we have to go through the prerequisites, I mean, the preconditions. So is the child able to learn? Because, wait a second, re-education means training or teaching, and this very much depends on the skills of the child. And then what about the motivation to growth and change? Let me translate this. It doesn't really sound very well in Italian, but when we try and verticalize children also with a PK, I mean, in the vertical posture, the response of lower limbs may be escaping the load. I mean, they don't want to load. Not all of them. I'm just telling you what motivation is. I'm telling you that sometimes we offer verticalization in children that don't want it. We offer it anyway. I mean, we know there are plenty of benefits, derived from, verticalization, but, this is a sort of a warning sign. I mean, the child is not showing any interest towards verticalization. We are offering verticalization, but he or she doesn't have this pre-requirement that should be very important. And then, can we really change the function? Now, this is a very specific parameter in rehab, and we can translate it in the following words. How much should I dare? I mean, for example, we have children, they walk with, orthesis. We may have, different, ambulation system. So anyway, they keep a functional organization, even if I change the so-called environmental support systems. Some children cannot be modified, or if they can, it's just a little bit. For example, if I adjust, the rigidity of the orthesis, they don't walk any longer. This is much more than a technical thing on how to build orthesis, but this means that I don't have to change. I understand, how much I dare, how many, let's say, adjustments I may offer to that child, and he or she has thresholds or limits. In PKS, learning skills have some key thresholds, or once again, limits concerning the learner, the child. This is sort of included into the pathology. It's part of the pathology. Learning means attention, motivation, or having the right, duration of their attention. They should be curious, eager to learn something, and then they really have to be resolute, wanting something. And we have to say that there are some limits or thresholds in terms of on the teacher side, on the physical therapist side. So their experience is based on, normally developing children, while in this case there's a pathology. So they have to be familiar with that pathology. Also in those cases where it is very rare, so we don't have many cases happening. It's difficult to make, let's say, benchmarking or comparisons. And there's another, difference. The child may be enjoying what he or she is doing. On the other side, the child does something just to please the therapist or the parent, or just to please, the adult asking to perform a specific function. There's also a crucial relational perspective, especially if you have major learning difficulties. In those cases, that's a frustrating experience. Because, it takes so long to have minor changes. But all of this has to be recognized and taken care of. So we have to be aware of our own limits as re-educators. This means we always have to be honest. From the intellectual point of view, we have to say exactly what we know and what we don't know. And there are two very special words here at the very bottom of the slide: magic and, something consoling, something comforting. You really have to be intellectually honest. Now, magic is sort of, feeling powerful. We don't have to be, let's say, to think we are more powerful than we are, sort of almighty. So we are not almighty, okay? We do have limits. Including, in medicine, people think we are almighty, so people think medicine can solve every problem. No way. On the other side, we have to say, well, some people say, no, it doesn't need, we don't need to do this, it doesn't change it, we keep doing it just because we are kind, or maybe because we are not intellectually honest enough. So these 2 points have to be taken into account. Re-educators always have to recognize their limits. There's another point on how modifiable a behavior is. I need to know exactly what can be modified for that child and how and when and how long it will take. So when should we start and how long should I wait before seeing a change? Because, you know, if you don't do this, well, you just start re-education without any time targets. You have different tools that have to be used together. You have therapeutical exercise or physical therapy. I have to say that in the severe impairment cases, many other tools are important as well. Orthesis, aids, with specific, let's say, problems in terms of tolerance in PKS. In some cases, children do not tolerate aids and or orthesis. This was, you know, built in order to facilitate, you know, the sitting position or the standing position or gait in general. Or they may have been designed to give assistance. For example, to move the child or to help him or her, you know, stay seated in those cases where disability is severe. Of course, we have drugs and functional surgery. Wait a second, functional surgery, but it's basically the same surgery also allows us to offer support or assistance. For example, the foot deformities of a non-loading child. All of this is into the, let's say, into the re-educator side together with assistance or support. Of course, we don't want to create a new function that is not there. So it's an aid, it's supportive. And you have a neonatal hypotony in many cases, but in PK children, we saw, I mean, spasticity or hypertone. If you combine this with growth, you have retractions, which also triggers deformities, which are not congenital, but they, you know, come with growth, so-called secondary deformities. So back on our cases, some surgical experience told us that there may be post-op, post-surgery complications, maybe not very important. For example, surgical lesions, you know, which are sort of difficult to recover. Let me conclude with this sentence from Thomas More. God, grant me the serenity to accept things I cannot change, courage to change things I can, and wisdom to know the difference. Thank you so much.
Complimenti alla dottoressa Silvia Alboresi.
Thank you so much for such an interesting
Sentita da parte di tutti noi.
An interesting presentation. We are slightly late, but I think we have 10 minutes for questions or curiosities. So I think, well, however, if you don't have questions, you can think over during the lunch break, and we will have a Q&A sessions also later on in the afternoon. Now, if I may be sort of an icebreaker, if I consider the very first presentations this morning by the group of Ravenna, you have been talking about dysphagia, and well, of course, this is one of the main or most frequently found problems in children. So we'd like to know what what you do in your organization, in your center. Do you have many people working together? Well, because of course, well, today we focus on Pallister-Killian Syndrome, but I think that some behaviors actually are common to different diseases. So your office is not always present in other centers or hospitals because, for example, in Bologna, we don't have it, or, well, we created it last year. But, I mean, my question is, well, you know, speech therapists and physicians, so many pediatricians, and many different figures working together. So I was wondering if actually such a collaboration is needed in order to actually obtain, you know, results and to work with children. Yes, this office was created 10 years ago by a pediatrician, Mrs. Marani, and she collaborated with Dr. Feletti, a speech therapy, and Maura Ricci, a physical therapist, expert in nutrition and swallowing and dysphagia. So when parents come to us, they meet a pediatrician and an expert in this field. And we have created also a network. So we also have another colleague in Turin, mainly dealing with endoscopic studying or assessment of swallowing. So we do collaborate with this person. We do also have other physicians we work with for example, rehabilitation. So altogether, we have created a sort of a network, or, I mean, people working together. And so, for example, we have our speech therapist following Anna, and I mean, the girl I talked about, and she always communicates with us. So we try to take care of all gastroenterological problems. Let me add that the specialists involved are physical therapists, speech therapists, and over time we had a sort of contamination. So I learned things from my colleagues and they learned from me. So we asked parents to take their children together with the rehab specialist, because we also do provide counseling. And so once they are at home, they try to follow our indications. And I believe that, you know, the fact that the office is at the hospital, this is very important. But, well, we also work with children on a daily basis, so we also know all the people contacting or working with children. So this is another important sign of a connection between the hospital and our territory. So, well, I think that there are a lot of families actually that, well, work together with many specialists, because, well, dysphagia is just the first issue. So if you start and take care of this as early as possible, then, you know, all the other issues might be improved. Any questions? My daughter has good swallowing, but she doesn't drink water. Now I'm diluting 1/3 of a juice and water, but I mean, when she drinks water, she starts coughing. She can't handle water. Can we improve this, or through some exercises, some practice, or she won't be able to drink water? Well, liquid dysphagia is a problem in children with hypotonia and difficulties in closing the lips and protrusion of the tongue. So they find it difficult to handle a liquid which goes everywhere. So, however, there are some things that we can do. So these are basically the identifying the most effective or tool, but then of course we have to move from suction to drinking, and also posture, and also containing or retaining maneuvers, and also the use of thickeners, because I mean, if water can't be handled, if you had a thickener, the perception of the child and also in the mouth changes a lot. So there are many things we can do in terms of rehabilitation, using the most suitable tools and maneuvers. So we actually also give the suggestion to have water mixed with some other liquids. But she drinks like 3 liters of liquids. So she likes and she needs lots of liquids because she has the risk of dehydration. We tried not to give her any liquids because we wanted her to drink water, but actually she didn't want to drink anything. So unfortunately, we had to hospitalize her because actually she had dehydration. So she drinks a lot, but she doesn't drink water. Well, the use of a thickener is not always accepted by a child. So sometimes we use one thickening agent, the child does not accept it. I mean, you also have to train the child who has to get used to something different, because we know that sometimes children like routines and they do not want to change things. Well, the speakers of this morning will be with us also in the afternoon. So if you have further questions, I think we can have our Q&A session later on. Now it's time for our break, lunch break, and we will resume our works at maybe earlier than 3 p.m. Let's say 2:50, 2:50. Okay, so we will meet at 2:50. If you don't have the voucher for the lunch, do you have it? Okay, we have like a coupon for lunch, so I will give it to you. Thank you, and see you later. See you.